That's right. And so one of the first things you often give them is, well, you give them oxygen, try to get their heart beating, try to get them breathing again, but what drug might you give them to try to correct their acidosis? Soda bicarb. Don't you give soda bicarb?
We're getting there. Yeah,
You're getting there?
We're getting there.
Yeah.
Paramedic level.
Yeah. Well, anybody that's been down for even a minute or two is going to be quite acidotic. And so one of the things that we used to always do when people were arrested, if you had an IV, one of the first things you did, besides giving them oxygen and do the ABCs of airway, breathing, circulation, is to give them some soda bicarb to try to bring their pH back up to near normal so that everything would start working correctly, like their heart. That's a really good thing to have working correctly. Okay. Let's talk about first order, second order, and third order neurons. And there's some really great diagrams in your book, and I really think you just need to work your way through that section and try to get this understanding. But basically, we have first and second degree motor neurons going down. We have first, second, third coming up, usually. The first order neurons are the thing that bring it in from the finger up here, and they carry it up here to the dorsal root ganglion of the spinal cord. Remember those guys? Funny root, sensory. Dorsal is always sensory. And there's always this big ganglion right there. Remember that guy? Motor is all coming out here. Sensory is all going in up there. Dorsal root ganglion. So that first nerve that came from that little receptor out there in your finger, that one nerve traveled all the way up here, and here's where its cell body was, and then its synapses, it goes in here to the spinal cord and hooks up with another one. So the second order neuron then starts there in the spinal cord and then heads up towards the brain. The third order neuron, the second one's going to go up to the thalamus. We talked about the thalamus being a weigh station to decide whether things want to go all the way up and become a perception in our brain, in our cerebrum, where we actually sense it. So third order neurons go from the thalamus up to the cerebrum. That makes sense? Now clearly, if you cut a nerve here, the messages aren't going to get up there. So if you cut a nerve here, you're probably going to have an area of numbness out here on your hand. You'd like to think that'll grow back. Maybe it will, maybe it won't. When I would take care of trauma patients, a lot of times they'd have a big cut on their arm here, and they might have cut one or two of the nerves going to their arm. And you'd take them into surgery, clean it all out, try to find both ends of the nerves, and try to cut them off nice and square if they were kind of ripped, and sew them back together real delicately, trying to get the nerves lined up like that instead of like that, or like this, or something like that. You know, you want to line them right up so that hopefully those nerve cells can grow back. And the really hard lecture that you had to give the patients, and they didn't appreciate hearing it really, was that, listen, you got to understand this. If this works, and I can't guarantee you'll get any feeling back in your hand, but if you do, it's going to grow back about 1 millimeter a day. So 1 millimeter, that's how fast nerves regrow. So think about that. That means 10 days to grow 1 centimeter, right? That's half an inch. So 20 days, 30 days, 40 days. You know, to grow from here down to there is going to be months. And you know, first they'll get a little feeling here, and that's a good sign because you know it's starting to reconnect. And then they'll get here and here and here, and gradually they'll get their feeling back. They may get tinglings and all that stuff first. But neurons heal very slowly. Oh, there's that picture. What a lovely picture. That I was trying to draw over here. This is much better. You know, gray matter, right? Sensory coming in, dorsal root, ventral root leaving out. All of these are white matter tracks, these things here, which you do not need to know all the names of. They draw 13 or 15 or 17 or umpteen of them. I'll just kind of leave it at that. You know, read the names because they are kind of helpful. If something is a spinocerebellar, where you figure it goes? It goes from the spinal cord to the cerebellum. And the spinothalamic tract, right there. These are posterior columns. These are muscle carrying fibers down. I believe that's right. Okay, let's talk about the sensory homunculus. I love that word homunculus. It doesn't mean near as much as it sounds like it should. But basically, it's a functional map of the sensory cortex. Now, where is our sensory cortex? Motor cortex is in front, the precentral gyrus. Sensory cortex is in the back seat. It's the posterior central gyrus. Okay? So, the whole sensory area of the other side of the body is laid out there in that precentral gyrus. Sensory would be in the postcentral gyrus. Okay? So, these guys started working this out and tried to figure out, well, what does that really look like? And so if you take this as looking at the brain like that, and this being the precentral gyrus, postcentral gyrus, once again, sensory, then this is what the guy looks like. And you notice that the tongue is pretty big, the jaw is pretty big, the face and lips are huge, because that's where all our sensory fibers are. And notice that the finger is pretty big too, the finger's in the hand, but then the whole rest of the body, the arm, the chest, the back, the butt, all the way down to the feet, really is not very sensitive. Then there's this other thing that's also not very sensitive that you guys don't appreciate this, but the genitalia are not very sensitive. They occupy a very small part of your brain, even though you might think about it a lot. They're really pretty small on the homunculus. The takeaway points are that the things that are most sensitive are our mouth, our jaw, our face, our lips, and our fingers. Okay, remember the baby. That's what they were stimulating because that's what was giving them the most bang for their buck, so to speak. They were getting the most feelings out of those things. So how do those messages get there? Well, they come in here, say fine touch or pain. They come in here, here's the dorsal root ganglion. They carry on, in this case, they go up the spinal cord somewhat to the nucleus gracilis, which I believe is in the medulla. They synapse here, here's the second order neuron, comes across, goes to the other side, goes up to the thalamus. Thalamus is the way station. It decides whether the message is going to get transported on. And so this is the third order neuron right there going on up to the brain, to the cerebrum. What's the point? Well, I've just made these points. It's the face, lips, jaw, index finger that get the largest part of the sensory cortex. Let's talk about another kind of pain called referred pain. This is a sensation that comes in. You've often heard that somebody who has a heart attack doesn't feel that pain in their chest, they may feel it in their jaw, or they may feel it down their left arm. Okay? By the way, in women, recent studies show that women more commonly get pain in their jaw than they do in their chest if they're having a heart attack. The symptoms of cardiac pain in women have always been confusing. That's why so many women get sent home from the ER with a heart attack. It's because their symptoms are really quite different than they are in men. And it took medicine a long time to figure that out, because, you know, women, gee, they're not supposed to get heart attacks, right? Men get heart attacks. But anyway, so that's a type of referred pain. Appendicitis generally starts around your belly button here, and the reason you get in pain there is because the appendix is starting to swell and you're feeling those stretch fibers that I talked about. But you don't localize it over here where your appendix lives, you localize it right here in the middle of your abdomen, just like all of your intestinal cramps. They just kind of go to the mid part of your abdomen. It's only when the appendix then swells and irritates the wall over here that pain moves over here. Well, that's another example of referred pain, the pain around the belly from the appendix. A couple other things to know about. Liver and gallbladder. When people would come in and I interviewed 1,000 patients that had gallbladder troubles, and I'd say, well, where is your pain? When you had pain, where was it? Oh, doc, it's right back there in my back. If they made that movement right there and put their finger and pointed back there, I knew it was their gallbladder. 100% of the time. That's just what it was. It was a very classic way that the pain went. Now this thing here describes the pain is going up here in your shoulder. Now it does go to your shoulder sometimes, but that's only when the gallbladder has swollen up enough to irritate your diaphragm, right? Your diaphragm. You guys ever gotten a stitch when you're out running? You're running and you get this pain in your top of your shoulders. That's your diaphragm. Your diaphragm is stretching, trying to breathe more for you, move more air because you're exercising, and you feel it as pain in your shoulder. It's from your diaphragm. Here's the heart we mentioned. Comes down the arm. It also goes up into the jaw. They're illustrating that really there. All of your intestines are kind of in the middle right there. I think that's about all I'd make of that. This one's pretty classic. A lot of guys, especially if they have a kidney stone blocking their ureter, which is the main tube that connects your kidneys with your bladder. When that gets blocked by a kidney stone, it stretches, and the stretching is incredibly painful. But they oftentimes feel it in their testicles. It's a referred pain. It's in the same dermatome, sort of. So they oftentimes just simply, they come in with pain in their testicles, not realizing it's really their ureter. So those are the referred pains you ought to be aware of. Spinocerebellar carries all of this proprioceptive information up there. I think I've worn you out on that cerebellum, me trying to stand on one foot. There's the pathway that's all going up on. There it is right there. So most sensory information is related to the thalamus. Only a small, it actually goes farther than that. Most of it gets weeded out at the thalamus. They say that's far enough and doesn't make it up to our conscious awareness. The visceral sensory pathways, the stuff coming from our guts, I think I've said that pretty well already as well. It's picked up by these interoceptors, monitoring mainly the stretch fibers. They're not near as numerous, but when they do occur, they can be very, very painful, obviously, from the stretch. Visceral sensory pathways, you may remember these cranial nerves, 5, 7, 9, and 10. Those are the ones that are sensory, that are carrying information up. 10 is the vagus, 9 glossopharyngeal, 7 is the facial. Remember, it goes to the mouth and some down there, and then 5 is the trigeminal from the face. So these are carrying some visceral sensory information back, and I'll just leave that at that. Okay, so now we're going to move, we've been talking about sensory. Now let's talk about the efferent system a little bit. The SNS, or the somatic motor system, or somatic nervous system, controls all of our muscles. Pretty important part of what our brain does for us. That's the SNS. The ANS is the autonomic nervous system. Also think of it as the automatic nervous system. It's the one that makes us, makes our heart beat, makes us digest our food, and so forth and so on. We'll get to that. We're going to do a whole chapter on the autonomic nervous system soon. All of the muscles in our body that get innervated by the somatic nervous system have two neurons that do the job. One of them starts up here in the brain in several places, CNS processing center, and then they go down and they synapse on the lower motor neuron, and then that lower motor neuron carries the information all the way down the spinal cord down to the muscle itself. Okay, so there's only two of them. Now, if somebody breaks their neck and severs their spinal cord, they've damaged their lower motor neuron. And indeed, when you damage your lower motor neuron, you can't get any messages through at all. So you become paralyzed and flaccid. You can't move anything below that point. So if it's the lower motor neuron that gets damaged, that's the outcome from it. Now that could be here too. And this is the lower motor neuron too that's heading out to the muscles down here of my grip, for example. And if this gets cut, same thing. It's paralyzed. On the other hand, the upper motor neuron is different. The upper motor neuron comes down and it can either stimulate or it can inhibit the motor neurons, the lower motor neurons below that. So when you see a kid with cerebral palsy, or Donald Trump with cerebral palsy, that's because of damage to their upper motor neurons. And thus this whole set of diseases that damage the upper motor neurons. And most of them aren't very good. So that upper motor neuron can make them weak, so they can't move it, but it can also make them hyper-reflexic and contractile, I guess you'd say. So the lower motor neuron is the lower down one, but remember it's going to go this way. Cell body is either in the brain stem or in the spinal cord, and the lower motor neuron is the one that triggers that, goes all the way to the muscle itself, and the end of that muscle is the neuromuscular junction that makes it happen. Corticospinal pathway is the main set of nerves that give you control over your skeletal muscle. You should look these up and see where they go, because the pyramids, that's why it's called the pyramidal system, right? Remember the pyramids that you could see on your brain stem there? That's where all these fibers are running through. And I'll just kind of leave it at that. Corticospinal cortex down. That's going to give us another homunculus. This is going to be the homunculus of the muscles. Okay? Now, where do you think most of the muscle signals go to? Which part of your body? What do you think is the most sophisticated motor organ that we have in our body? And I'll tell you, you're listening to it right now. It's the larynx. Think about the amount of muscle control that is necessary to move your vocal cords apart and back together and control the tension so you can talk down here. You can change the tone of your voice. You can say things like S, G, G. All of those are incredibly well controlled muscles in your larynx. Actually, your larynx gets more fibers than really anything. Your face gets a lot too. That's why you can make so many faces. Here's the homunculus. This is the motor homunculus. And notice, once again, the whole body really doesn't get very many. Your hand is pretty sensitive. We can do really fine things with our hands. Our face and tongue, we can do amazing things with our tongue. But the biggest one by far is the larynx, your voice box. So all of these muscles come down here through the corticobulbar tracts, go down through the medulla oblongata, cross at the pyramids here, right below the pyramids, and then go down and connect to the spinal cord right here. This is all the upper motor neuron pathways down to here, and then this is the lower motor neuron pathway heading out. I would recommend you review that in your book because there's some pretty nice things. So the thing you need the most muscle control for is your face and lips and tongue and your larynx. Think about how sensitive your mouth is next time you're chewing a piece of steak. You chew it and your tongue moves it around a little bit, moves it to the right, moves it to the left, so that there's no part of that bite of steak that you haven't crushed pretty well. And then you sense that it's, well, okay, I guess it's about chewed up well enough, and then you swallow it, right? All of those muscles back in your mouth are so talented, I guess is the best thing to say. The cerebellum, talk just a little bit about it because it's the thing that really does this position thing. And I've already talked to you about standing on one foot and how important the cerebellum is in that. And believe me, you can stand on one foot a whole lot better if you have your eyes open, because you're also getting input from your eyes as well as from all those proprioceptive fibers in all your joints. Your balance is also coming from your inner ear. That's going to help you with balance. Romberg test is a simple test. Actually, and the police do this when they stop you for DUI. You stand with your arms out like this, and you should be able to stand pretty steady. And then close your eyes. And if you close your eyes, almost everybody will move a good bit more, okay? Because your eyes give you such important information into your cerebellum and your brain to help you stay balanced just right. Then the policeman will have you touch your nose too. That's another thing that's really hard. You ought to practice this if you're ever going to drink and drive. You shouldn't drink and drive, but if you want to pass the test, man. Saw an ad the other day, $10,000 for getting a DUI. Okay, real quick, I'll take 3 minutes here to talk about neural tube defects. I think these are really important. You don't have to take notes on this. This is just for your interest. We strive to teach you normal A&P instead of abnormal diseases, but I can't help but talk about a few of them because they're so fascinating. This is a series of the problems that occur with neural tube defects. And the lowest level is this one right here, which is called spina bifida, because you notice the bone doesn't extend all the way around. This is the spinal cord. This is the meninges. This is the skin. The next step is when the bone is gone and also the meninges extend way up. These kids are born with a bump on their back. But you notice in this one that the spinal cord isn't out there. In this one here, the spinal cord is out there. And in the final one, there is no skin over it, so it's just open. These kids usually do not survive very long because their spinal cord is open to the weather back there, and it's lots of infections and so forth. They've actually started trying to close these defects in utero by doing surgery on the babies while they're still in mama. and trying to free up skin and bring it together and sew the skin together so they have something covering this, because otherwise it's just a nightmare. This is the last stage in the defect. This is where we're talking about the neural tube closing around the ventricles. Remember, this is anencephaly. This is a baby with no brain. Basically, it never sealed at all. And as terrible as that is, there's a lot worse ones on the internet. You can go to the anencephalic parents website. These are some of the lesser ones with the spinal cord out on the back. Here's an example of hydrocephalus. This is a kid, or this is an older person actually, that is dead. And you see how big their ventricles are? That's because the drainage couldn't get out. There was a blockage somewhere in the cerebrospinal fluid tract, so that they were making more spinal fluid than they could. The way these are usually treated, if they're diagnosed early enough, is they put a little plastic tube in here into the ventricle, run the plastic tube out to the skin here, and then pass it down underneath the skin from the head, under the skin down here, and then stick it into the abdomen. And it has a little one-way valve on it, so that the fluid, when it's made up here, goes, instead, since it can't get out normally, it drains and just dumps into their abdomen, and then the body reabsorbs it without any problems down there. Here's a stroke. This is a patient who had a blockage to the blood vessel. Looks like the middle cerebral, just from looking at this area on the brain. Here's what it looks like there. This whole area is dead, probably led to the patient's death. Nice, you can see the, on the walls of the ventricle in there, you can see the, what do you call those things that make the CSF? Called the choroid plexus, yeah. Strokes, most strokes are caused by this. There's just arteriosclerosis buildup and then breaking off little pieces of it. We used to do a lot of operations to clean out the carotid arteries called carotid endarterectomy, where you just peel all that stuff out and give them a nice clean artery again, hopefully before they got to this stage here, where it's a big bleed into the brain up there. Here's a berry aneurysm. These are called berries because they look like berries. This is obviously a cadaver person. Big, huge aneurysm, just a weakness in the wall of the artery led to that big swelling like that. When these things blow, it's like taking a fire hose and shooting it into the jello, basically, and they do very poorly.
How does that happen?
Huh?
How does the aneurysm happen?
We don't know. I mean, they just have a weak spot in their artery. The most common place to get those kind of aneurysms is around there. The second most common place, well, actually the most common place in your body to get aneurysms is in your abdomen, in your abdominal aorta below your renal arteries. Also in your popliteal arteries behind your knee and up in your brain.
Can you feel that stretch?
A lot of people get a headache, and that'll take them in to get them a CAT scan or an MRI, and if they get an MRI or a CAT scan, it'll show up.
And then they can have surgery or no?
Yeah, you can. They go in and put little clips across it so that the blood can't get out into the aneurysm anymore. That takes the pressure off the aneurysm and should, here's Alzheimer's disease, which where these webs form in the brain, so all the connections between the cells don't connect properly. Multiple sclerosis is a patchy disease that comes and goes, looks like that on a CT scan, and that's it. You know what? I was going to do the quiz right now, but I forgot to bring the answer sheets. I'll just go get them. Otherwise, we'll do it over in lab.